Good evening, sir.
Hi, good evening. Just give me 1 second. I'm trying to.
So just a second before that. Am I audible? I'm trying a new phone.
Just 1 minute. Let me just. I'm trying to set up the. I'm trying to set up the
Good evening,
YouTube
sir.
link. YouTube link. Good evening. Just give me 1 second. I'm trying to.
So just a second before that. Am I audible? I'm trying a new phone.
Yeah, you're audible.
Who is Germina Felix? Yeah, I can hear you, Saumya. Can you speak up?
Yes, sir.
Yeah, I can hear you very well. Don't worry. I'm just trying to set up the YouTube link. So we are live now on YouTube as well. There was somebody trying to log in, which was not a known name. I've removed. Okay, so that's good. Okay, now share your desktop, please. Share screen.
Yeah.
Just 1 minute. I'll allow you to share. Yeah, 1 minute. Share your screen, please.
Is that okay, sir?
Not yet. I can't see your screen. You need to press the green button.
Not yet. Okay. I'll do it again. I keep saying host has to.
Yeah, I just gave you the permission. So share it.
Okay. Is it coming up now?
Not yet.
Not yet. Okay. Okay.
What is happening when you now it's coming. It's coming. Wait. So it'll come. Just give it a second. So you've started sharing your screen. I can see it, but I can't see your screen. Just it's coming. Okay, now go into slideshow mode. Yeah, that's good. Perfect. Perfect. Keep it like that. And what I'll do is I'll set this up to. So we are on. Good. And let me just start recording. We still got time. So we've got 5 minutes, Saumya. Okay. So how are you going to play this? Are you going to make it interactive or are you going to make it a lecture? How would you want to do this?
Sir, I think see how it goes. If it goes as a lecture, if you feel that it's going to be boring, then probably
No, it's not about boring. It's just if it's interactive, then you have to stop yourself and ask the question. That's the thing. It's not about boring or not boring. It's whatever you do, it's fine. But interactive will be where you have to ask the question before you show your slide. And if you are doing a lecture, then you just carry on.
Others feel about being asked questions and all that. So somebody is listening and want to give an opinion on it. And
okay, so you just make it as a lecture if you want. That's not a problem. I will just 1 minute. I'll just set this up. But they are to
So is the fan in the background causing a noise?
No, that's not. Your voice is very clear. Don't worry about it. But go back into slideshow mode.
Okay.
And just push your camera down a little bit, or bring your laptop so that it's like a passport photograph, your view. At the moment, I can only see your head. See, my view is from the waist up, from this up.
What happens is when I go to slideshow, I cannot see myself.
Okay, don't worry. Okay, that's fine. Not to worry. If you want, try.
A lot of Zoom control that I'm not.
That's okay. Don't worry. I am here to control the Zoom for you. You just have to focus on your WhatsApp. I'll do all the other things. Not WhatsApp, on your PowerPoint. So now, can you see yourself? If you come out of your screen show, you will be able to see yourself. Just come out of the screen show 1 second. Just concentrate on the PowerPoint. Okay. Forget Zoom. Yeah. Okay, that's better. That's much better. You're okay. The camera is fine. Okay. So we'll just wait for a couple of minutes, and I'm sorry about all this time problem, because the British summertime has ended today. And in UK, when the summertime ends, you move to 1 hour behind. So the whole thing is a mess. Pause the recording. Okay. Just 1 more minute and then we'll start. Yeah.
Sure, sir. Need to thank IACTS as well, isn't it, sir?
Yeah, don't worry about that. You just go ahead and
go
ahead and give your lecture as it is. IACTS is logging on to the. But you can, if you want to thank them, that's okay. But don't worry about it. You're already live on the IACTS website and you're live on YouTube.
Okay.
So, but no pressure. You just do it as you would normally do for Thoracic Gurus. Everything else I'm controlling, so you don't have to think about it at all. Okay.
Yeah. So I'm going back to slideshow.
Yeah, go back to slideshow. Okay, we're ready to start. Okay, I'll just start the recording. Good evening, ladies and gentlemen. Welcome to another session of Thoracic Gurus. We are now in the exam mode as the FRCS exam is coming really close. And today's topic is extremely important because you will be asked this scenario either in your long case, short case, or definitely in the oral and vivas table. And also a lot of stuff which is going to be presented here today is actually going to come in the MCQ. So at least 1 or 2 MCQ comes on cardiopulmonary bypass. So I would suggest you pay attention to the discussion. And if you want to ask any questions, you can ask questions. Please make the notes and ask the questions at the end. I'll be very happy to act as a moderator for our speaker today. So let me introduce our speaker today is Dr. Saumya Ramanan, who is an assistant professor in pediatric cardiac surgery. And she has kindly lectured to us previously on pediatric cardiac surgery on this forum. And today we are very delighted to have us with us. She works at Sri Chitra Institute of Cardiac Sciences. She is, as you know, Sri Chitra is one of the premium institutes in South India, and the training in cardiothoracic surgery at Sri Chitra is probably one of the best in the countries. Thank you, Dr. Ramanan, and please take over, and the floor is all yours.
Thank you, Dr. Khan, and thank you, IACTS, for the opportunity. I'd like to start my topic. Before that, I would like to thank all my teachers and for all the hand-holding and for the training and the shouting and the advice, and all teachers of past and present. And I'll just go into the topic proper. If your current CPB handling style is this, then you definitely need to listen to a lot of points that we're going to discuss today. So the points we'll be discussing under several sections. One would be an overview of cardiopulmonary bypass. I'm touching on a lot of points which are probably very basic, but it would help some of the, it would be a revision for most of us, and it would help some of the people who are just entering the specialty to know what is being done and why it is being done. What I've attempted is to give an evidence base for all the procedures that we have been doing. Each center has its own way of doing things, and I've tried to get it into perspective of what is currently accepted and what recommendations, if any, are there for the current practice. And then I have like intermixed it with some troubleshooters. I have tried to highlight the safety checks that we need to be focusing on. And also, I've tried to highlight at every point on how to avoid trouble, because that should be the emphasis rather than going into trouble and trying to get yourself from a mess. Okay, to start with, most of my talk is based out or extracted from these three papers and textbook. The EACTS and the EACTA had come up in 2019 with their guidelines on cardiopulmonary bypass. It's a very exhaustive 40-page document wherein each and every aspect of cardiopulmonary bypass is touched upon, especially in adult cardiac surgery. They don't have much focus on, the paper doesn't focus on pediatric cardiac surgery. I have also looked at the relevant sections from Gravely, which is the book that we all have to be reading before we enter cardiopulmonary bypass, and also some points on anticoagulation from the STS database. Now, to start with, the focus, the prime, apart from the patient, is the circuit. Without the circuit, the cardiopulmonary bypass, there is no cardiac surgery, at least still for 70 to 80% of the surgeries that are being done. We should all be familiar at this point, and those of the newest people who are not familiar should be familiar with the circuit and how it works. The circuit, this diagram is taken from Gravely. CPB starts, as we all know, with systemic heparinization, and then we start with the aortic cannulation, the venous cannulation. The flow starts from the venous end. It goes to the venous reservoir. That's the connection to the venous reservoir. From the venous reservoir, the blood goes to the heart-lung machine or the pump proper. This is the connection, the blue arrow, the thick blue arrow shows the connection from the reservoir to the pump. From the pump, the blood goes back to the heat exchanger, from where it goes on to the oxygenator, and from where the oxygenator blood starts making its journey back to the patient through an arterial filter, and then across the aortic cannula. Now, essential is anticoagulation. We need to know some basics of anticoagulation. What we should know is unfractionated heparin is the anticoagulant of choice during CPB. How it works is binds to antithrombin. It potentiates inactivation. And how do we monitor? By using ECT, which is a whole blood coagulation test, which tests the intrinsic coagulation system. Factors pertaining to the patient, surgical factors, temperature, hemodilution, platelet counts, all tend to affect ACT. And both heparin and protamine tend to prolong the ACT. Now, what is the dosage of heparin? They use a starting dose of 300 to 500 units per kilogram. And during CPB, ACT is monitored regularly and the dose of heparin is titrated. We try to achieve target values between 300 and 600 seconds. Most units aim for an ACT of more than 480 seconds during CPB. If you're using a heparin-coated circuit, then probably you can have a lower ACT, 250 seconds to 350 seconds as safe. It can be considered safe and effective. Before going on bypass, it is mandatory to go through the pre-bypass checklist, wherein you look in at patient details, sterility, whether the heart-lung machine is powered, connected, startup is normal, if you have backup power, the heater cooler, the connections verified, the gas supply, pump, tubing, the safety alarms, the oxygenator, and a whole bunch of things which we will be going through in detail through the rest of this talk to see why this checklist is important to be checked before we go on bypass rather than going into bypass and then looking for options to get out of trouble. Use of bypass is again a class 1 recommendation as per the current EACTS guideline. So whenever I show a column like this, and I have not actually put it in every slide, but these tables are directly taken from the EACTS guideline. And it is a class 1 recommendation again that every unit before surgery goes through a surgical safety checklist timeout procedure. Now we start with arterial cannulation. That is the first thing. We've seen a whole bunch of cannula being available on table, and as surgeons, we have to decide what cannula we are going to choose for the procedure. The way we go about it is looking at the procedure per se, patient characteristics like whether it is adult or pediatric surgery. For adults, you would probably use like the angled cannula or the straight cannula or the extended angled cannula. For pediatric, you're more likely to use cannulas such as the DLP cannula here. The site of cannulation is also important. What is important to know is that the arterial cannula is the narrowest part of the ECC. So high flow through narrow cannulas, high pressure gradients, high velocity jets, can cause turbulence, cavitation, and undesirable consequences. Long catheters with a uniform narrow diameter, they are undesirable for the conduct of cardiac surgery. And you should, like if you're using something which has a thin metal or a hard plastic at the end, that gives the best internal to external diameter ratio, and the flow is better with it. If these are some of the considerations which we would look at from the surgeon perspective, if the same question were being asked to your perfusionist, like what cannula should I take and how do I choose my cannula, he would come up with something called the pressure drop, which is the difference between the arterial end pressure and the patient pressure, the pressure they measure at the patient end. And based on this, they also sometimes calculate a performance index. Performance index is calculated for most of the cannulas that are available in the market. And it is, like I mentioned earlier, it is important that the narrowest portion of the catheter that enters the aorta, it should be kept as short as possible. This is important for the cannulas which don't come with a flange or a marker which shows how much needs to go in. So you need to determine how much of the cannula goes in. So you have to decide where you're going to have that cutoff. So the smaller portion that you're able to retain within the aorta, also keeping in mind that the cannula shouldn't come out during the entire course of the surgery. And we'll also come across graphs like this, which essentially reflect the pressure drop and how much pressure is generated through the aortic or the venous cannula. In this case, the aortic cannula, 100 millimeters of mercury pressure gradient is what is taken as acceptable pressure gradients. Excessive pressures lead to hemolysis and protein denaturation. And looking at sizes of pediatric cannula that are available, anywhere from 6 to 16 French pediatric cannula and adult cannulas of 21, 24 angled and straight tips and 20, 22 ear per cannula, the ones that are commonly used. The common venous cannulas, again, depending on the site of the cannulation, the patient characteristics based on the body surface area and the maximum flow rate that you want to achieve. Between the venous ends, end of the patient and the pump, the accepted gradient is 40. Again, you find graphs like this which show the flow rate which is possible through a venous cannula. The M number was a number which came up briefly during the course of cardiac surgery, where numbers were allotted to cannulas based on the gradients they generate. I doubt if anybody still uses them except for the manufacturers. It is also important to know that 1/3 of the total flow comes from the SVC, and 2/3 of your total flow is going to come from IVC in an adult. The ratio will probably be reverse in neonates and children. And presence or absence of LSVC, and when you cannulate the LSVC, whether you cannulate the LSVC, whether you're going to use a sump after you open the heart, or whether all the various options for LSVC cannulation also need to be decided. Now again, what needs to be decided is tubing sizes. When you're deciding tubing sizes, the main intent of deciding arterial tubing size is how much of prime can you minimize while allowing adequate flow rates and minimal line pressure. Just a simple maneuver like a moving the pump head closer to the patient can help you reduce a significant portion of the prime that you're going to be using. And based on the tubing, some things are important. The internal diameter of the tubing will decide the smaller the internal diameter of the tubing, the lesser prime volume you will end up taking. The chart again from Gravely. If you're using a quarter-inch tube, the volume will in per feet will be 9.6 ml. If you're using a 3 by 16 tube, I'm talking about pediatric sizes here. If you're using a 3 by 16 tube, the volume would be 5.4 ml per feet. So if you're assuming that there is 6 feet length of arterial line from the pump to the patient, and you're able to, you choose a 3 by 16 cannula tubing instead of a quarter-inch tubing, there again you achieve a decrease in priming volume by 27 ml. Now, what also needs to be kept in mind, like similar to the aortic cannula, the arterial line is also, if a narrow arterial line can also add on to higher line pressures and higher shear stress. So in the enthusiasm of reducing priming volume, you should not compromise on the line pressure that is going to be generated, because that can cause greater hemolysis. While deciding venous tubings, we actually do the reverse. We tend to choose the bigger sizes that are available for the same dimension. So instead of using a 1/4 inch, if you're able to use a 3 by 8, you would be increasing the flow rate by at least 2 liters per minute. Now, some of the common size ranges, like from neonates to young children, mostly we use either 3 by 16 or quarter-inch tubings. When the 13 to 35 kg weight group, it's mostly quarter tubings, and more than 35 we use 3 by 8 tubings. When it comes to the adult, we tend to go to a half-inch venous tubing. Now then again, all the discussion on coated and non-coated circuits. Coating reduces systemic inflammatory response. So as much as possible, you try to coat the circuit and the oxygenator. What is available in the market is ionic or covalent heparin, phosphorylcholine, PMEA, trillium, and all the surface modifications can be applied either after the tubing is manufactured or during the manufacturing of tubing. It has been shown that if you combine both tubings and oxygenators with non-heparin based coatings or biocompatible coatings, you find that you reduce platelet transfusions, reduce the lactate levels, and overall you have better post-operative lung function. Most of the RCTs and the trials that have been conducted reflect these. And it has therefore come up in the recommendations as well. So what is first recommendation is that there should be a preoperative agreement between the perfusionist and the surgeon on the choice and size and type of venous and arterial cannulas and the tubings that are going to be used. And they need to be tailored to the needs of the patient and the procedure. That you agree it should be a class 1 recommendation. And then the other recommendation, like I said, is that use of biocompatible coating to reduce post-operative complications. Now, I also said we'll be looking at emergency scenarios during the course of the talk. So some basic rules when you're dealing with emergencies. You can always and should always go off bypass if you think you're in serious trouble and call for help. Now, whether you go off bypass or not depends on what stage you are in. Have you just gone on pump? Or have you arrested the heart? Is there any structural heart disease? Are you doing intracardiac, extracardiac repair? What drugs can help the patient? You need to be aware of all these things to get you out of trouble. And if you are asked, are you closer to fixing the problem that has arisen in CPB? Or are you closing to finishing your surgery? Would you think that you should be finishing up your surgery and then solving the problem? I think you should always solve the problem and then finish your surgery. So just to boost our talk a bit, we'll go to the first clinical scenario that is there. You're on bypass with an aortic and a single stage RA cannula. The heart is reasonably empty. You're asking your assistant to retract the heart for IVC cannulation. suddenly you hear a lot of noise and commotion, you find that the RA cannula has come out, it has got pulled out slightly and it is sucking in air, and you have air in the venous side of the pump circuit. And you have what is known classically as the airlock. Now what do you do next? Now to manage this, there are certain CPB related steps you need to do, and there are certain patient related steps that you need to do. The CPB related step would be like to stay cool, go off bypass. We are really early in surgery to cause any serious trouble to the patient by going off bypass at this stage. Just make sure you have filled up the patient adequately. Newer machines actually have level sensors that go off on their own. So probably the first alert you would hear is from your perfusionist saying that he cannot run the pump anymore. In this case, you reposition the cannula, or you fill the venous line with saline, or you chase the air down the venous column, depending on how serious the problem is. Now, patient-related steps that you need to take, you have to alert the team. You have to ask the anesthetist to give volume from the head in. He has to resume ventilation if you're going to go off bypass. You have to check for air in the arterial side of the bypass before resuming bypass. Now, a situation like this should not happen. What precaution you need to take is you need to practice care and caution while handling the purse strings and the cannula. Now, as we know, there's a lot of hardware used in cardiopulmonary bypass. It is essential or imperative that you know what is being used. And it is just not a perfusionist territory alone. So there are two basic designs to the pump that we use. Simply by the way of deciding whether the pump is stationary or the pump is an ambulatory system. Now we are all familiar that for most of the cardiac surgery that is being done, we tend to use the stationary pumps, whereas the ambulatory pumps we tend to use for bedside procedures or for integrated ECMO circuits or something like that. Now, all anesthesia associations that are available, like the American Association, the Australian Association, they all suggest certain important or unavoidable parts of the heart-lung machine. One is that you need pressure controllers, air detectors, low-level alarms, electrical safety specifications, and it should be possible to have a reversal of flow for the pump in case of a runaway pump. Manual operation of pumps should be possible with the use of crank handles. All pumps should come with integrated light source and batteries for operation in case of power failure. Then we also know that there are roller and centrifugal pumps, and we keep going on back and forth about advantages, disadvantages of roller pumps. Just to quick brush up of what is what for the newcomers. Roller pumps are nearly occlusive. They are afterload dependent. They require low prime volume, low cost. There is no potential for backflow, shallow sine wave pulse. Excessive occlusion from the pump can cause positive and negative pressure, which leads to spallation, tubing rupture. And there is always a risk of air embolism in the roller pump. Now, in a centrifugal pump that is non-occlusive, it is afterload sensitive. It requires a large priming volume. Cost involved is high. It has potential passive backflow. It is safe for positive and negative pressures. It adapts to the venous return. After the initial phase where you need a higher priming volume, it adapts to the venous return, and then you're able to flow for what is available. It is superior for isolated right or isolated left heart bypass, and also for long-term bypass. And it protects against massive air embolism because it just shuts off when air enters the system. Now, what is the data available? Lots of data, but none of them are conclusive either for or against the use of roller pumps or centrifugal pumps. So the recommendation for using centrifugal pumps figures is only a class 2A recommendation in the IACS guidelines. Now, when you're talking about roller pumps, again, you need to know about the occlusion setting of the pumps. It's something we said that greater occlusion can lead to blood trauma and tubing trauma. So you can do this by increasing or decreasing the compression of the tubing by the rollers. And the double rollers are more occlusive than single roller pumps. And how you do that is you hold the outflow line vertically so that you get a good length of water column or a prime column in the tubing. And then you gradually decrease the occlusiveness till the fluid falls at a rate of 1 to 2 centimeters per minute. Now, with the tubings that are available, you are able to give a range of blood flow. With a 3/16 tubing, you are able to give a blood flow of 1 liter, and with a 1/2 inch tubing, you will be able to give a maximum of 8 liters of flow.
Dr.
Now,
Saumya, sorry to interrupt.
Yeah.
May I suggest that just slow down a little bit, because I can see people are writing notes.
Okay.
And if the slides move too fast, they are missing some very important points. These are excellent slides. So just slow down just a little bit so that people can make some notes as you're talking. But thank you for a great talk. Thanks. Continue. Yes. Please continue.
Okay, sir. Okay. So do you want me to go back on any of the slides?
No. Just continue. Carry on. Because we are recording, they can always go back and see it. But from here on, just go a little bit slow as you move the slides, so that they have some opportunity to make some notes as they are listening to you.
Sure, sir. Sure.
Thank you.
Sure. Okay. So second scenario, a troubleshooter again. You are operating on a 60-year-old man, and the case is aortic stenosis. Now, the procedure that you have planned is aortic valve replacement. And you have an uneventful initiation of cardiopulmonary bypass, and you have clamped the aorta 6 minutes after starting cardiopulmonary bypass. The aortic valve is replaced uneventfully. Aortotomy is also underway, meaning like you're close to ending your surgery. At this point, patient temperature is around 34 degrees, and suddenly you're hearing alarms from the pump. Now you can see a lot of motion running around in the OT. The arterial pump, you can see, is accelerating. There is no way it is being controlled. It's not being manipulated. You're not able to manipulate it. Now the situation that you have at hand is a runaway pump, and you have one of the older machines or something, and the reservoir is completely drained of blood, and there is gas in the arterial line, meaning like you have a situation of an air embolism now. Now, how do we go about this? So again, steps can be into cardiopulmonary bypass related steps and patient related steps. Now, going on to the CPB related steps. First step, turn off the pump. The key is you're not able to turn off the pump because you're not able to control the pump at this point. Now, what you can try to do is to turn the pump rotates in a clockwise direction normally. What you can try to do is turn the speed control knob counterclockwise. Again, if this is going to help, will depend upon the pump that you're using or whether in this particular situation this is possible or not. Like I said, the newer machines would go into an auto cutoff mode when the levels fall in the reservoir. Now, what you need to do at this point is to change the pump head to the backup pump head. Now, how do you go about that? And you also need to refill the arterial line so that no air is getting pushed into the patient. Okay. So you need to disconnect the venous line and the arterial line, recirculate if needed. If the amount of air in the circuit is too much, you need to recirculate, disconnect, recirculate. Then restart CPB after you have connected to a new pump head. Now, the time available for us to do all this, it depends upon the patient temperature. Now, like I said, we are in 34 degrees. 34 degrees doesn't give us too much of a leeway to, do this in a very relaxed way. So obviously your perfusionist needs to call for backup. You need to call for backup so that there are people around to help you to do things. The first thing that you need to do from your side is to clamp the arterial line. Second thing is you need to clamp the venous line. You have to, your anesthetist has to give a steep head down. And you have to initiate steps for massive air embolism. I'm going to be going into massive air embolism in detail in subsequent slides in a different scenario. So at this point, just know that you need to initiate steps for massive air embolism. And your anesthetist needs to give drugs for cerebral protection. Now, is this preventable? Yes, runway pumps are reported when there are power surges in the circuit. You need to ensure that your system works with a separate high ampere point, which is going to be used exclusively for the heart-lung machine. And the other checkpoint that you can have in your system is use of arterial filters. And arterial filters will act as a stopgap, and they will prevent massive air embolism in such events. Like why I'm specifying arterial filters again is many units compromise on the use of arterial filters because of cost issues. And once this episode is over, you need to go back and do extensive checks to identify the reason for why this thing happened in the first place. Like you need to even go back to your electricity wing and see if there was a surge from their end which could have been controlled or predicted or something, or if you could have got a heads up on some possible voltage fluctuation that's about to happen or something. So the event needs to be evaluated in detail. Now, some other integral parts of the hardware that we use, the reservoirs. The reservoirs can be open reservoirs, which these are the open reservoirs. The hard shell ones are the open reservoirs. They are easier to manage. They have larger capacity. They are easier to prime. They are less expensive. The issues with reservoirs are that these reservoirs, the open reservoirs, are that they can cause hemolysis. Then there is a lot of non-gas embolism that can happen from the components of this reservoir. And there is a risk of massive air embolism if you're not using a level sensor, which comes with this. The other option would be to use a closed type reservoir, which is a soft collapsible bag. What you can see in the corner, this corner of the picture in this corner. These soft collapsible bags, they eliminate blood gas interface that you see in the hard reservoirs. Like in this picture, it's a hard reservoir. You can see the blood gas interface here. The same blood gas interface does not come in a closed type reservoirs. And they reduce the risk of massive air embolism because it just collapses. The bag collapses and you're no longer able to conduct cardiopulmonary bypass. Now, oxygenators. Previously, oxygenators and reservoirs used to come as two separate units. Now they come as an integral unit. What you're seeing on top here is the reservoir, and what you're seeing here below is your oxygenator. So oxygenators were initially in the beginning of history of cardiopulmonary bypass. They used to be large, clumsy film oxygenators that were later replaced by bubble oxygenators. And what we are using now are the membrane oxygenators. Membrane oxygenators are way safer than the previous versions of oxygenators that we have had. They cause less particulate and gaseous microemboli. They are less reactive to blood elements, and they have superior control of blood gases. The membranes are usually made of polypropylene, silicone, or polymethyl pentene. Having said that, how close are we to getting what the natural lung offers? You will see that way less than what the natural lung has to offer in terms of the maximum oxygen transfer that happens across the membrane. Now, what is the recommendation? Microporous membrane oxygenators are the recommendation, again, class 1. And I said polymethyl pentene or PMP is a membrane oxygenator that is used. But these oxygenators are not preferred if your anesthetist is going to be giving volatile anesthetics during the procedure from the pump side. Okay, now we go to the third clinical scenario that I have. You have a 60-year-old. This is an actual scenario which was published in JECT in 2012. Now, it's a 60-year-old man and who's undergoing a redo CABG for blocked grafts. Now, you have gone on CPB with aortic and two-stage RA cannulation. You're doing ABGs sequentially. Your 40-minute ABG shows that the PaCO2 or the PCO2 levels are not acceptable. Then you go back and look at all the PCO2 levels that are available. You see that from the commencement of CPB, when it was 5.6, it has gradually gone up to 8.75. Now your perfusionist feels that he can no longer run the pump with these values. At around 30 minutes, he has tried certain measures to try to reduce the PCO2 levels, which have not worked. Now he feels that the oxygenator needs to be replaced. Now, is that an easy proposition or not? Okay, so again, we go to the CPB related issues. Now, again, oxygenator change is not a task for a single person. A single surgeon and a single perfusionist cannot handle oxygenator failure and change of oxygenator. You need to call for help and assistance. You need to have a backup emergency oxygenator in hand, preferably within the room. That will make it a short procedure. You need to go off pump. You have to clamp the arterial and the venous lines. You need to double clamp the arterial line and the venous line and the recirculation line. And the oxygenator that is giving you trouble, it has to be cut off from the circuit. It has to be like cut and divided between clamps in a sterile fashion. And a new oxygenator that is primed has to be connected between these clamps. And you have to connect the gas line to the new oxygenator. You have to remove the clamps and prime the oxygenator. And whatever residual air is there and anywhere in the circuit, you try to purge it through the arterial line filter. Or if not, you disconnect the arterial line from the cannula and you have to de-air from that end. Now, what are the patient-related steps that you need to do at this point? The patient has to be cooled. One advantage is that it is a slow process and you're aware that it is serially rising and you know that it is going to be an elective change of oxygenator, which has to be done quick. So you have the option of taking a few minutes to cool the patient before you stop circulation. So that gives you time to get things in place and to make a swift change, like probably a tire change during a race. Then you have to have cerebral protection measures in place. This is not an entirely avoidable situation, and so you need to have a backup oxygenator. That is probably one of the key things that you can do for reducing the damage. And early identification like this is essential. So like other issues that can happen with an oxygenator are that unrelated to an issue like this, other issues that can happen are that pre and post oxygenator pressure gradients can rise. That could be the alarm given to you by your perfusionist that the pressure gradients are high and I'm not able to flow. And you would end up seeing clots in the oxygenator. Not supposed to happen again. It is something which is inherently wrong with the oxygenator, which is giving you trouble like this. But you need to be aware and you need to act fast. So going on to gas line blenders, because oxygenator, a fault of oxygenator is kind of closely related to your gas supply which is there and how much oxygen is going in, how much carbon dioxide is coming out, and how are you going to regulate this. So it could be your lack of ability to oxygenate or lack of ability to remove carbon dioxide, could also be because of other issues pertaining to the gas supply to the oxygenator. So for that, you need to ensure that a continuous gas supply is required for the OT and that you're not operating out of gas cylinders, oxygen cylinders, or that is not a source of oxygen supply. All oxygen, air, carbon dioxide, everything, you should have a backup supply in the room or anywhere where you're planning to perform an ECLS. Monitoring of gas supply and gas exchange is paramount to the safe conduct of CPB. And when you're using volatile anesthetics during CPB, again, monitoring of anesthetic gases and scavenging systems is imperative. So these are some points where you can have trouble. These are the gas filter and the oxygen analyzer are safety points. You can have trouble in the blender, you can have trouble in the gas flow meter or the vaporizer. Any of these could be trouble points which could mimic an oxygenator trouble. Now, what are the causes for reduced oxygenation? It is a most frequent incident that happens in CPB circuits. The gas delivery system can develop a leak or blockage. It could be something as simple as a faulty connection of the oxygen line to the vault port. It could be just a loose connection which is giving you trouble. Or it could be something as silly as forgetting to turn off the gas before going on CPB. Or it could be that the gas line is not connected to the oxygenator. Then the most important thing is a defective oxygenator. Or it could be something like blood flow rate is more than the gas flow rate, for which you have, going back to the picture, you have the flow meter. The flow meter actually also helps you to regulate flow of the gas and the sweep rate and the flow of the gas, which will help remove PCO2, which was the first step that the perfusionist had done in the previous case when he saw the PCO2 rising. And then when he felt that that was not helping, he identified an oxygenator defect. Okay, now going on to heat exchangers again, they've come integrated with the reservoir oxygenator coupled with that. The function of heat exchangers is to add or remove heat from the blood. Why is this needed? One is that you need to control patient's body temperature during surgery. The reason for that is one, as blood flows through the extracorporeal circuit, it tends to cool. So you need to actively keep the patient warm, or you need to deliberately lower and restore to normal thermia during CPB for a smooth performance of your surgical steps. So there are procedures which want you to have a bloodless field, and it having a hypothermia for that sometimes helps. Now, like I said earlier, because previously they used to be separate units, and now they are part of the disposable oxygenator. Now, what are the optimal sites for temperature measurement? Routine core and cerebral measurement is what we need to do, and there are several sites. So probably the sites used in your center would be a rectal probe and a nasal probe. But there are other sites. There are sites where they use the Foley's, the indwelling Foley's comes with a temperature probe in it, which just needs to be plugged into your probes and temperature sensor of the CPB machine. What are the best sites for measuring temperature? The pulmonary artery and the jugular bulb. But then it is difficult to get these probes in place, so they're not routinely used. Now, again, I said about temperature management and why it is required. We often hear terms like flow for temperature, and we know that oxygen consumption is less during lower temperatures. So, what are we actually talking about when we say such things? So, if you see this first table, you'll see that when the patient's body temperature is 37 degrees, oxygen consumption is at its maximum. As you gradually come down and you go to 28 or 25 degrees, oxygen consumption comes down to half. And when you go down further, this comes down even further. So when you come to the predicted flow rates that are required for temperature, you'll see that if you're at a temperature of 30 degree, you need to flow only 44 ml per kg for maintaining adequate oxygenation, that is cerebral metabolism. And this rate again comes down when you come down to 25 degrees. You need to flow further less and further less when you go down to 18 degrees. Now, when do you need such situations? One is when you're anticipating to go on total circulatory arrest, or like I said, when you're doing an intracardiac repair and you're having significant return from the collaterals, and you would want to go to low flows to visualize some difficult corner of the VSD or something like that, intracardiac, small technical detail you want to do in low flows. For that, it is better if you're having, if your temperature of your patient is less. And then situations where you feel that the flow that you're in is inadequate for end organ perfusion. Like you have gone on a femorofemoral bypass and you feel that you're still a long way from putting in an additional cannula. Your sternotomy is getting difficult. After your sternotomy, there are a lot of adhesions. You're not able to identify structures. So putting in a second cannula to get a better flow is going to be difficult. And also in emergency situations, like most of the emergency situations which we discussed up until this point, you're required to go off bypass. Now, it is safer for you when your patient temperature is somewhere in the moderate hypothermia range, because oxygen consumption by the body and oxygen consumption by the brain is less at this point of moderate hypothermia. And if at all you need to cool, the drop in temperature is going to be like to achieve a further drop in temperature to go on TCA, it is going to be easier to achieve that target than if you are at normothermia and you have to come all the way down to 18. Now, there are three ranges of hypothermia that we accept. The mild hypothermia, which is 30 to 34 degrees, moderate hypothermia, and deep hypothermia. Now, the problems of hypothermia, like I said, there are advantages to hypothermia and there are problems with hypothermia. Hypothermia increases the viscosity of blood. Now, you need most units, at least pediatric units, prior to surgery, we decided we would like a target hematocrit of 30. Now, you need to keep the hematocrit at 25 if you're going to go for deeper ranges of hypothermia. The 20% hematocrit is what is best if you're going to be in deep hypothermia. And during rewarming, packed cells undergo protein denaturation. So either while cooling or while rewarming, hypothermia can get you into trouble. The gases are going to be more soluble in cold than in warm blood. Now, as you start warming, it is important that you maintain a temperature difference of 5 to 10 degrees between your heat exchanger, between the patient end and the venous reservoir end. So your heat exchanger has to be set only for this gradient. Mainly because gas emboli happen during rapid rewarming. Now, what are the recommendations? It's a very busy slide. I'm just going to make it simple for you. You need to measure. The first set of recommendation is that which is the best site for monitoring if you're looking for a surrogate for cerebral temperature. The answer to that is your oxygenator arterial outflow point is a best surrogate. And if that cerebral perfusate temperature will correlate very closely to your arterial outflow temperature. So again, like if you don't have any other monitoring in place and you want to get an artificial idea of what is happening in the brain, this is a class 1 recommendation that you just need to measure the temperature at your arterial outflow. Now, the second recommendation is that you should never rewarm to more than 37 degrees so that you avoid cerebral hyperthermia. Third recommendation that you need to focus is the gradient that I was talking about. More than 10 degree gradient, 10 degrees Celsius gradient can generate a gaseous emboli. So you need to keep it less than that. If your temperature is already patient temperature is already more than 30 degrees, you need to keep that gradient or for rewarming at less than or approximately 4 degrees centigrade. It's a class 2A recommendation. So, I'll just interrupt to find out if the speed is okay. Sir?
Yes, ma'am.
Yeah, perfect. It's
Okay.
absolutely perfect.
Yeah, thank you. Going on to the next scenario. You have a 10-year-old boy, 20 kg, is being operated for an ASD. Now you have an aortic cannula in place, bicable venous cannula in place. You've started CPB. You have attained adequate ACT. 2 minutes after CPB, your mean arterial pressure was showing 30, temperature was showing 34, ECG trace was fine. Suddenly, a perfusionist says that he is not happy with the venous return and that he is not able to give full flows. Now, what could be causing this problem for us? It was all smooth and suddenly the venous return is less. Now, circuit-related issues are more common. You should check the venous line for airlock, things, any mechanical reasons for decreased airflow. Is the person standing on the assistant end pressing on the venous line by mistake and blocking it? A simple reason, but known to happen. Now, if you have not found any of these reasons, you have to cross-check the size of the cannula and the tubings. We have already come to an understanding that this is the size of the arterial line and this is the size of the venous cannula. This is the size of the venous tubings that you're going to use. Now, oftentimes what happens is your nurse gives you a venous cannula and you put it. You don't bother to cross-check at that point if that is the cannula that you had agreed upon. You just assume that your nurse has given you the right cannula for that particular thing. So you need to go back at this point of time and cross-check that the venous cannula sizes are correct for the patient, and that is what you agreed upon. Then if that is also right, what else could cause a problem? Now you have to check if any positional change in the venous cannula will improve the drainage. Now that is also not helping. Then you try raising the height of the table because in a conventional CPB, venous return is gravity assisted. So if raising the height of the table will increase the venous return. That should not be the solution if everything else that I've agreed upon is right. One problem, what can happen is in angled IVC cannulas, they can enter the hepatic veins. So it helps if you change the cannula to a straight-tipped venous cannula. Or the other problem that you have not recognized is that there are clots in the cannula despite your adequate anticoagulation. So a change of cannula, if any of points 1, 2, 3, 4, none of these is helping you to get rid of your venous return issues, it always helps to change the cannula so that you know that you've taken care of that. Now, if it is not any of these things, you need to look at the patient factors that have gone wrong. Look for the heart size. While your perfusionist is saying that his venous return is less, does it reflect in the heart? Is your heart full? If your heart is adequately full, then it means that you're having cannula-related issues at the patient end. If your heart is empty, then you look for reasons if like a PDA or a major collateral that is stealing the flow from your circuit. Known to happen that you have missed a PDA or a major collateral during your pre-operative echo or an intraoperative TE. And these are blind areas, not often visible. So your anesthetist or your cardiologist doing a pre-op TE would not have helped you out with a PDA or a major collateral. That could be giving you trouble during bypass. Look for those factors. If it is not any of these factors, then the only next thing is the ominous thing, and that you have gone in for an aortic dissection. Again, aortic dissection I'll be dealing with later, so I'm not touching upon that at this point. So are these preventable causes? Yes. Could you have saved yourself and your unit a lot of time? Yes. How do you go about doing that? Is that after you go on bicable cannulation and before you clamp, it is important and it should be a part of your surgical checklist that you do a trial total bypass to make sure that you are able to give adequate flows for temperature. And that your SVC and your IVC cannulas are independently able to give you the flows that they are supposed to give, the 1/3, 2/3 formula that we spoke about. Okay, now going on to another clinical scenario. It's a 50-year-old male undergoing a mitral valve replacement. You've gone on pump smoothly. You've just cross-clamped. Until this point, everything was fine. You've just cross-clamped. And then your perfusionist is saying line pressures are high. Now, what has gone wrong? Okay, now in this case, we'll start with the patient factors first. You have to make sure that the cross clamp is not including your aortic cannula. Sounds very silly, but happens. A lot of times it happens. And the other thing is the important one, dissection. Have you dissected while applying the clamp? Now, for this, you have to ask your anesthetist to look for TE, or you have to look for an epi-aortic ultrasound, depending on what is available. Now, the other CPB related things you ask your perfusionist to do is if it's not the cross clamp, including the arterial and something as correctable as that, you need to immediately come off bypass, remove the clamp, reduce the flow, try manipulating the arterial line to see if that changes the flow. And if none of this is helping, you're still not sure what is happening, you consider peripheral cannulation, and then you strongly move in towards the steps that you need to take for a dissection. Now, the preventable things which can give you, which can mimic an ominous situation are, one is that if you're using a straight aortic cannula, the bevel of the cannula, it is ideally supposed to face the arch. Or in an angled cannula, the angle is supposed to face the arch. Either of these cannulas could be facing towards the heart. And when you clamp, the blood is going to be hitting a closed end. and then going back to the arch. So that could explain your rise in pressures. If that is the case, when you remove the cross clamp, your line pressure should become better. The other thing that usually happens is you have cross clamped, and there is you end up fixing the cross clamp to the drapes. You either use that with a silk or with a towel clip or something. You try to hitch the cross clamp to the drapes. When you're doing that, you tend to kink the aortic cannula. So that the posterior wall of the aortic cannula, of the aorta now hits the tip of your aortic cannula. So both these things are correctable causes, which could probably be the reason for higher aortic pressures or high line pressures when you've just cross-clamped the heart. Again, keep this in mind, and while you're looking for it, you really need to rule out a dissection before you proceed further. Now, the next couple of slides are recommendations for practice during the conduct of cardiopulmonary bypass. Priming volume and autologous priming. How important are they, and what should you look for? We know that we discussed earlier on why you need to have a lower hematocrit, or why hemodilution is important, especially in the context of going into hypothermia. Apart from that, your priming volume is a volume that is going to be in your reservoir. That is what your perfusionists use to fill the reservoir and the circuit before blood comes into the system. So that is going to cause hemodilution, it is going to cause coagulation issues, and it is going to cause fluid extravasation if it sets off the inflammatory pathway. Now, different types and combinations of priming solutions have been used. Some are crystalloid, some are colloid. There is no consensus regarding the best priming solution that is available. Crystalloids are preferred in a lot of European centers. Colloids such as albumin, gelatin-based solutions, HES are supposed to be preferable for several reasons. One is that adding colloids, especially like albumin, it reduces fluid extravasation and edema formation, especially in smaller children. You would prefer to add albumin to your prime. Now, adding a solution such as a HES to the system, it is shown that it does not cause any difference in post-operative blood loss, but it is shown to cause increased risk of acute kidney injury. Now, use of dextran 40 based solutions, again, allergic reactions can happen. So, plus minus everything is there for priming solutions. Mannitol reduces the risk of acute kidney injury is the report of several small studies, but review of literature has not found any concrete evidence to suggest use of mannitol as well. Now, what is a recommendation? Recommendation is only class 3 recommendation, use of low molecular weight starches, priming solutions, non-priming solutions, all these things leading on to decreased bleeding. All those things don't figure out much in literature for us to have a concrete recommendation for this is what needs to be used. But what is figuring as an important recommendation is that many units are now trying to go to retrograde and antigrade autologous priming as part of blood conservation policy to reduce transfusions. Now, how to calculate priming volume? This is again something which we used to know when we were learning, but I don't know if many of the residents still know about it. So what decides how much volume of blood you add, volume of fluid you add to the blood is that the target hematocrit that you're going to look at. So if you're targeting a hematocrit of 30 on pump, you make this calculation. You look at the patient hematocrit, you look at the patient blood volume, and the total priming volume will be based on the target hematocrit. Now, if your target hematocrit is 30, and for the unit, it recommends that 30 is the target hematocrit, and you're not able to achieve that, then you need to add some blood, extra blood. Apart from patient blood that is going to come in, you need to add some extra blood into the prime. And how you calculate that is the blood volume plus total prime volume into the hematocrit this side minus the blood volume into the patient hematocrit. Now, again, the short forms are explained. RBC is a packed red cells that you're going to add. the blood volume of the patient, test patient weight into corresponding blood volume from the chart. There is a chart available for this. It's there in Gravely. You look at the total priming volume, the circuit plus the total patient's blood volume gives you the total priming volume. Hematocrit decide on pump and the hematocrit of the patient. I would really suggest that if you've not been looking at it, you need to go back and discuss this with your perfusionists and how they calculate it, and that would give you a better idea of what is done. Now, I said autologous priming, either antigrade or retrograde is the recommendation. That helps to reduce the amount of crystalloids or colloids that you're going to use for priming volume. It also reduces the amount of blood transfusions that you require. Now, in this, the patient blood displaces the circuit blood into an external reservoir, either in an antigrade or a retrograde manner. And then this external reservoir is excluded from the circuit. To know this, to know what all this means, what usually is being done is the blood that comes from the venous end, it goes to the reservoir. Up till this point of time, all this was with crystalloid or the priming volume, which you have circulated in these lines. Now, when the patient blood comes in, this starts moving slowly, dislodged slowly. The crystalloid then goes into this fluid bag. As soon as blood reaches this point, you clamp this line, and then you remove clamp 3, and then you go on to the arterial end. Now, what is retrograde priming or retropriming? In retropriming, this step is avoided. Instead, the arterial line blood also ends up going to the reservoir, or you tend to just fill this entire, chase out this entire priming volume into the fluid bag, and then fill this with patient blood. So you have replaced, you've tried to replace this much, or like 30 or roughly 30 to 40 ml of blood with the patient blood. Now, to do a retrograde priming, you need to be in sync with your anesthetist. Patient BP should not fall. Many of these patients are in poor hemodynamic status, and your anesthetist should be in sync with you to do a retrograde priming properly. Autologous priming is more in vogue when you're using the minimized CPB circuits. Again, I'll be coming to that later. Is it useful? Yes, RCTs have shown, meta-analysis has shown that retrograde priming is helpful, or autologous priming is helpful in terms of reducing blood transfusions. When you're looking about organ perfusion during CPB, you have to look at, there are certain terms which keep coming in repeatedly. You need not know all of this at this point of time. You just need to know some terms so that when I'm speaking about it, you will know what we are referring to. One is DO2, which is a measure of global oxygen delivery. You want it to be roughly 1 liter per minute during CPB. And the VO2 is a total oxygen consumption. There is some term called the oxygen extraction rate. Again, complex formulas to calculate it. But now I'm just mentioning it so that you will be able to follow what the guidelines are mentioning. Yeah, you can go back to this slide at a later point of time and go through these details. Now, when you're targeting pump flow management to cater, now what is it that we use right now? Now, most units use body surface area and temperature. And we tend to target blood flow for the body surface area and the temperature. Body surface area per se is not an adequate measure of metabolic needs, especially if you have an obese patient. Body surface area doesn't help. Instead, lean body mass is considered a better substitute for measuring adequacy of perfusion. Again, I said your adequate pump flow in these cases, where you can again lean body mass, not easy to calculate. So how do you know? Then you measure the DO2, the global oxygen delivery. So and the pump flow needs to be titrated to the DO2. It is said that your post-operative acute kidney injuries usually happen when your pump flows are lower. So renal function, again, amount of urine that is formed, indirect indicator of whether your pump flow is adequate or not, or if your perfusion is adequate or not. Then there are other markers of inadequate perfusion. One is low values of SVO2, or mixed venous oxygen saturation. If you have a nurse that is connected to the patient or a near infrared spectroscopy, values of nurse help to find out whether perfusion is adequate or not. What if you get an indication that your oxygen extraction is high or your lactates are high? Both are again indicators that your perfusion is not going correctly. Your oxygen extraction should not be high and your lactate should not be high on pump. So what are the usual pump rates that we're talking about? When you're talking about children, children have obviously they have a higher pump flow based on body surface area. You get in mostly somewhere between 100 and 120 is a safe number to say for both adults and children. What is the ideal blood flow that you want to flow? You can say I want to flow somewhere between 75 and 100 for adults and 100 to 120 for children. That would be a good enough answer. Now, what is your recommendation? Recommendation is that the pump flow earlier was, if you don't have any other measure, then you stick to your body surface area and temperature and plant temperature as your guidelines, class 1 recommendation. Now, if you have other parameters to check oxygenation, then you should be using those, class 2 recommendation. Your parameters like SpO2, oxygen extraction rate, NERS, lactates, all those things, class 2 recommendation. Then again, like I said earlier, lean mass is better in obese patients. How we calculate, difficult to find out. Now, monitoring during CPB, we have the usual monitors which everyone uses, the arterial blood pressure. The pump flow is titrated to the arterial blood pressure, and you have get a sense of adequacy from the blood gas analysis. That is what is done, at least basic minimum procedures. Now, other parameters which we looked at recently, the saturation, oxygen saturation in the venous line. And continuous blood gas monitoring are gaining more prominence. We are getting class 1 recommendation now. Regional cerebral tissue oxygenation measurement using NERS, oxygen delivery measurement using DO2 as a parameter, depth of anesthesia measuring using NERS and EEG, all class 1 recommendations in the current guidelines. Now, busy slide, just need to know certain points. We often hear alpha stat acid-base management. What is the recommendation? 2A. pH avoidance of acidosis, 2A, and use of magnesium for prevention of arrhythmias, 2B. I don't think you really need to know 2B and 2A. It is just to give you a sense of how much these parameters are important when you're actually managing a patient. If you manage to get at least the body surface area and temperature right, good enough, because that is class 1 recommendation. All the other recommendations are added just to improve and keep fine-tuning your practice to get better and better results. Now, what is the mean arterial BP that you need during bypass? That is again something which we all think of and what we need to know. Your pressure range is should be between 50 and 80 millimeters of mercury. That again taking into consideration depth of anesthesia, target blood flow, everything. Now, you don't need to use vasopressors to increase pressures more than 80. 80 is good enough on pump. Now, when you're coming off bypass and then or during bypass, you feel that the patient has got a vasoplegia and is dilating. What are the drugs that you use? You can use drugs like alpha-1 adrenergic agonist. You can use drugs like vasopressin, terlipressin, methylene blue, or hydrocobalamin. These are drugs that names you should be familiar with, and you should be aware that you can go into something called vasoplegia on cardiopulmonary bypass. Now, again, we hear pulsatile perfusion. How important is it in current recommendations? 2A recommendation. If you're able to give a pulsatile perfusion, it prevents post-operative pulmonary and renal complications in high-risk patients. So if you have a high-risk patients, you can use it as the mode of perfusion of choice. Now we did come across DO2. Now what is, now there are current units which are slowly moving towards making that as a primary measure of measuring adequacy of cardiopulmonary bypass, and that is being termed as goal-directed hemodynamic therapy. So all your inotropes, your pump flows, everything is based on what your DO2 is going to look like. Now, what is the routine use of EEG and NIRS? 2B recommendation. Then you should have a hemoglobin more than 6 on pump. If you are not able to maintain adequate hematocrit, adequate ACT, what are you going to be using? Most units use FFP. FFP is still a choice, but there are a lot of units which are moving towards antithrombin concentrate as such. Okay, use of MUF, PEEP, ventilation, high-dose dexamethasone, lot of topics that are discussed by your anesthetists and all that, all 2B recommendations. Now, just to touch briefly on minimal invasive extracorporeal circulation, it is an amalgamation of all the things that you're trying to reduce primal volumes and all the reduce all the negative effects of extracorporeal circulation. So you eliminate whatever is possible. Okay, you eliminate whatever is possible, like a cardiotomy suction. You go into cell salvage, you use shorter tubings, you use closed systems, you use coated tubing, centrifugal pump. All these things are what contributes your minimal invasive extracorporeal circulation. Now, recommendation to use that is 2A. There are units which use that over conventional CPB. And using biocompatible, everything that comes, and that is 2A recommendation. Now, again, a weaning checklist is imperative. Just as a pre-bypass checklist was imperative, weaning checklist is imperative. Weaning is a multidisciplinary effort. Use of checklist is important to optimize safety. And it is also important, like a pre-bypass or an intra-bypass troubleshooter training sessions and simulations. Weaning scenario should also be trained and validated through interactive training sessions and simulations. It's a class 1C recommendation. So what all things go into your weaning checklist? Whether your blood gas, hematocrit, hemoglobin, electrolytes, all those things are within normal limits. What is the filling status of a patient? How much of blood is left in the reservoir? What is the patient position? Is it neutralized? Cardiac assessment rate, rhythm working, pacemaker working, ventricular function working, contractility working. You look at the cardiac preload by looking at the CVP. You look at the afterload by looking at the mean arterial pressure. You look at valve function. You look at amount of DR in both these last two things on transesophageal echo. Whether the necessary drugs have been started, whether the inotropes are ready and started, whether blood products, coagulation factors are available, whether protomin dose has been calculated by your anesthetist, whether you have a cell saver standby. There are times when you want to come off and you feel that you're bleeding, you have bleeding points, you want to give protomin and you want to come off, come fast and start protomin, but you still feel that there is some amount of bleeding possibility, you would want to have a cell saver standby. Whether your monitoring function alarms have been reactivated. We usually go off all the alarms and all the sounds on the monitor when you're on pump, and when you've arrested the heart, you want to have a silent OT. So your anesthetist has gone out of his way to silence all the alarms. Now you have to go back and reactivate all those alarms so that you're aware the ECG tone, the pulse tone has to come back on the monitor, and you have to actively listen to those monitoring tones that are available. The next most important thing, there are many times you see that your surgeon is just waiting for nothing, you're not aware why he is waiting or what she's waiting for. And then you are hesitant to ask, just look at the monitor and see what the temperature is. Sometimes the patient is not adequately warmed. And most surgeons want to have a patient rewarmed up to 35-36 degrees before they come off bypass. Now, what is the reperfusion time? And you have to make sure that the reperfusion time is met. Reperfusion time is the amount of time the patient has been supported by cardiopulmonary bypass after you've removed the cross clamp. The cross clamp is a period of ischemia. You're removing the cross clamp. Blood is coming back to the heart. You're reperfusing the heart. So how much time do you spend on reperfusion? Usually you take a tenth of the CPB time. So if your CPB has gone for as long as 120 minutes, sometimes like you spend around 10 to 15 minutes just supporting the heart on 36 degrees before you come back and take off the clamp. And during this waiting time of rewarming and reperfusion, you get a sense of how good your cardiac function is as well. And that will help you discuss with your anesthetist and decide whether you need additional inotropes or different inotropes and what you had initially planned for. A lot of things come into picture during this time. Now you have to mandatory, you have to ensure, you have to ask, confirm, reconfirm with your anesthetist if your ventilation has restarted. Because the moment you clamp and go to a single venous line or you start loading the heart, unless the patient ventilation has started, you're going to start another set of issues. Now, all members of the team have to agree that it is a safe time for you to come off cardiopulmonary bypass. Having said that, at any given point of time, you should be ready to go back and reinstitute cardiopulmonary bypass. Urgent bypass is a different thing, and reinstitution of cardiopulmonary bypass on table are entirely different thing. Two entirely different things. So there are situations where your whole team has to go back, go on emergency or urgent bypass. Like there is a crash and you want to go on ECMO or eCPR. You need to go assemble the pump, or a post-operative patient you've explored in the ICU, you want to go back on pump, emergency, your team has to be ready in place with a cardiopulmonary bypass. Most units go into trial sessions so that the entire team is ready and aware of how to go about this. It cannot be a one-off situation where you start looking for where is the pump. Everything has to be well-oiled, machinery has to be in place for you to go back to that point. Now, if you're thinking of reinstitution of CPB after weaning, like you've come off bypass and you feel that you need to go back on bypass, the heart doesn't look well. So you have a certain other set of protocols in place which you need to look at before you do that. Like I said, emergency training sessions, simulation sessions have to be in place. For these emergency procedures, you can always have a sterile setup ready. It could be a primed circuit or a dry circuit. For reinstitution of CPB after weaning, it is better if you keep the whole thing sterile till the patient's sternum is closed. Many units wait for the skin also to be done before you hand off the lines to your perfusionist. So two different things and two different ways of handling it. Either you can, in an emergency situation, you need to have a system ready, primed and dry, or if you have not yet gone off the table, you keep it available till you can you are sure that it is safe to come off. Now again, it is most important when you are planning to reinstitute or institute cardiopulmonary bypass, you have to ensure again and again that your anticoagulation is adequate. Sufficient heparin has been administered and that heparin has had time to act on the body. 3 minutes is a rough time for heparin to act, and you have to wait for that time before you institute cardiopulmonary bypass. Your ACT has to be in order before you institute cardiopulmonary bypass. Okay, now there are some, we talked about primed and dry circuits which can be used for emergency procedures. A primed circuit can be kept for 72 hours. And dry circuit can be kept for up to 30 days. And again, it's an institutional policy whether you need to have something like this in place or not. And how frequent does your unit go into trouble for you to have something as a backup like this? Okay, again, most of the things that we've covered. And that kind of finishes most of the recommendations from the EACTS guideline. Now I'm going to go into some of the other troubleshooters that I had in mind that we would be discussing, and probably a detailed discussion of some of the more important problems that we need to avoid. Now, one is redo surgery. Now, the next thing is redo surgery. It's an 18-year-old boy, 58 kg, height 170 centimeters, previously has had an intracardiac repair. Now, this boy has come for pulmonary valve replacement. Your pre-operative CT scan and chest X-ray both show that the heart is too close. CT is showing that the RA-RV is too close to the sternum. Now you feel that it is uncomfortable. You go on femoral bypass before sternotomy. Now the plan is that at some point of time when you're comfortable and when you have access to other the cardiac structures, you will convert it into conventional CPB. In femorofemoral CPB is only for you to tide over the sternotomy and make a safe sternotomy. Now you have put a long thin walled venous cannula, and you have ensured that under TE guidance that it has reached the cavo-atrial junction, that the cannula is in place. And suddenly again your perfusionist is unhappy. This venous return is not good. He feels that table adjustment, gravity siphonage is not helping. Now what can you do if there is inadequate venous drainage? Again, remember from the previous situation that we discussed, you check for airlock, check for tubing line, reposition the venous cannula, control the table height, increase height differential, check the CVP, check if volume replacement is there, all those things have been done, anything which can increase the return. Again, change the venous cannula. If you're using a hard shell venous reservoir, the next option which all of you would agree upon would be to use a vacuum. Then you use a vacuum and your venous return increases. You're able to go on flows. Now, what is assisted venous drainage? Now, 3 methods are possible to increase your venous return using assisted venous drainage. One is you use a roller pump between your venous cannula and the reservoir. It has its own set of issues. It is a high risk thing. Excess negative pressure, collapsing of RA and the great veins around the cannula tip, all these things can happen. Then it requires your constant attention and adjustment of the roller pump flow rate. The next option is use a centrifugal pump. When you use a centrifugal pump, this system is then called a kinetic assisted venous drainage. The third option is use a vacuum. That's the simplest option. You use your wall suction or a separate suction unit, and you regulate it to get a negative pressure of 20 millimeters of mercury, and that you attach to your hard shell venous reservoir. And this generates a vacuum and that improves the venous line. It's relatively simple, does not require a regulation and does not require a second pump, which requires constant scrutiny if it is working or not. Now, what are the safety precautions when you're using assisted venous drainage? You have to measure both the positive and the negative pressure that is being applied in the cardiotomy circuit. And you have to make sure that your vacuum does not go stronger than 60 millimeters of mercury. Before you apply vacuum, you have to wait for a while so that some venous return is achieved, and then you have to apply vacuum. And similarly, you have to discontinue the vacuum before you come off bypass. Now, advantages are that a smaller diameter catheter and a small priming volume is enough to run the pump in these cases. Drawbacks, and that is the more important one, risk of aspirating gross air and microscopic air into the circuit, hemolysis. Your venous reservoir chamber can have positive pressure, and air can end up entering the right atrium. What is the recommendation for using vacuum-assisted drainage, especially for minimal invasive surgeries or when your venous return is not good? It is a class 1 recommendation, provided that you're monitoring the venous line pressure at all times. What are the newer venous cannulas which are available? These are the femoral wired cannulas available in sizes from 8 to 40. Your non-wired femoral venous cannulas, again available in sizes, slightly bigger sizes, overall length. Then you have 3-stage venous cannulas. You can see three entry points for blood. And then your cavo-atrial cannulas. Now going on to venting. Venting is an integral part of cardiac surgery. You want to decompress the left side of the heart. So for that, you use several options for venting. You use the aortic root, you use the right superior pulmonary vein, you use the pulmonary artery, you use the left atrium, you use the left ventricle. Now, several sizes of vents are available, pediatric and adult. Usually it ranges from 10 to 20. They come with stellate, without stellate, bendable, several forms are available. And PA, this is how the PA vent looks. And when you're using the LV air aspirating needle, it comes in just one single size of 5 vents. Now, hemolysis is augmented whenever there is an air-blood interface. So vents are a source of air, are a point of air interface with blood, and venting can increase your hemolysis. You should give specific instructions for the amount of, the rate at which the vent pump is going to be regulated to the perfusionist. If you feel the vent is sucking in too much air, you have to ask him to go down on the occlusion of that pump. Vent is also a source for gaseous microemboli to enter the arterial line. This takes us to our next clinical scenario. Again, something which was published in 2009. An elderly man undergoing aortic valve replacement, routine cardiopulmonary bypass. They have used a 2-stage venous cannula, antegrade and retrograde cardioplegia, and they have used a left ventricular vent. Bypass was initiated, then there is distension of the heart. The surgeon feels that probably there is some return somewhere, and he's asking the perfusionist to cool. Then the assistant, he notices a lot of air in the vent line. Now, is that normal? No, that is not normal. Now, what is next? What has happened in this case is the vent line was hooked backwards in the CPB machine. So instead of aspirating blood and blood from the left-sided chambers, what is happening is you're actively pushing air into the left side. This has resulted in a massive amount of air being pushed into the heart, and now you have a full-blown stage of massive air embolism has happened, and you have not noticed it for a while. Avoidable? Yes, completely avoidable. You should have checked the vent beforehand. If it is sucking, if there is a negative suction on the vent, or which way the vent is moving. What are the CPB related steps that you do for massive air embolism? First, foremost, immediately stop, disconnect the vent in this case, but immediately stop the bypass. You check for air in the arterial and the venous lines. In this case alone, because you know that the vent is a source and you have identified it, you can actually continue CPB if you're sure that there is no air in the arterial line, that air has not entered the arterial line for some reason. You can, sometimes when your heart is continuously ejecting blood, air mixed blood, your arterial line can end up having air bubbles when you stop. So you have to make sure that air has not entered the arterial line, and you can continue CPB if you're sure that there is no visible air in the arterial line. If you can clamp the vent, clamp the arterial line, and clamp the venous line, fill the heart, then stop CPB if that's possible. Then you initiate measures for retrograde cerebral perfusion. You give retrograde cerebral perfusion for 1 minute via the superior vena cava. Then you simultaneously de-air the left-sided chambers, LA, LV, using a root vent or a LV needle aspiration or an aortic root aspiration. You correct the vent, resume CPB, and complete the procedure. Is it as simple? No. Several patient-related things also have to happen simultaneously in air embolism. You have to ask for a steep Trendelenburg position. You have to ask the anesthetist to initiate neuroprotective measures. First is to give methylprednisolone, 30 mg per kg. Then thiopenton, 10 mg per kg is the loading dose. What you're trying to achieve is a barbiturate coma, especially if the embolism has happened during warm cardiopulmonary bypass. You will not cool the patient. Then the next measure would be to give mannitol to reduce the intracranial pressure. Though I have written thrice a day and all that here, you give a loading dose during this acute phase, then you continue this into the post-operative period. Then you can ask anesthetist to exert pressure on the carotids when you're coming off retrograde cerebral perfusion. What if there is coronary air? Like I said, air can get pumped into the arterial line, air can get pumped into the coronary as well. So you maintain a higher perfusion pressure, either pharmacologically, and even after that, when you've gone on bypass, you have to maintain higher perfusion pressures to push the air out of the coronaries. Now, what is retrograde cerebral perfusion? You place the patient in steep head-down position. Arterial cannula is removed. You purge the circuit of the air. Now, this arterial line is connected to a cannula which is placed in the SVC. Now, what are other options for cannulating of the superior vena cava? This is your classical retrograde cardioplegia cannula. And this is an inflatable venous cannula, SVC cannula, which you can manually inflate. The bulb can be manually inflated. Both these options are available for you to use. In this case, we had read that retrograde plegia was already in place. So all you need to do is take out the cannula from the coronary sinus, place it into the SVC. Or if you have gone on a bicaval cannulation and air embolism has occurred, it is easier for you. Your SVC cannula is already in place. So you disconnect it from the venous line and connect it to the arterial line. Now you start flows at 100 to 200 cc per minute, and gradually you can go up to a higher flow rate of 1 to 2 liter per minute. The flow rates mentioned vary in different books. I found in Gravely that 500 to 600 ml per minute is considered as acceptable. So probably starting at a low flow rate, 100 to 200, going to 500 would be good. But what is an indirect indicator of adequacy of flow is the monitoring of the SVC pressure. You have to make sure that your SVC pressure doesn't go above 25 millimeters of mercury because it can cause venous hypertension to the brain. Then while you're doing all this, you try to cool the patient to 20 degrees. Whatever blood comes into the iototomy has to be sucked out because that contains air, it has to be sucked out actively. You continue retrograde cerebral perfusion usually for a period of 1 to 2 minutes, but until the arterial system is cleared of air. You have to make sure that the arterial system is cleared of air before you terminate it. And like I said in the previous slide, toward the later phase, just before termination, you ask the anesthetist to compress the carotids. That will push the air through the vertebral system. That acts as another form of de-airing, which will help you re-establish antegrade flow. Then you resume standard bypass and you continue to be in hypothermia. What are the other measures useful in air embolism? The picture shows a hyperbaric oxygen chamber. Obviously not during the cardiopulmonary bypass, but later on in the ICU, if your unit is equipped with a facility like this, you can use it. Now, when you are on pump, you have to make sure that you don't rewarm to excess of 35 degrees. Even when you're discontinuing the bypass, it's preferable that you remain at 35 degrees. And throughout in the ICU, it is better you keep the patient slightly cool for cerebral protection. The patient has to be ventilated on 100% oxygen, deep barbiturate coma like I mentioned previously. Hyperbaric treatment is the gold standard treatment that is recommended. It is useful up to 48 hours of injury. Mean arterial pressure should also be kept slightly high to push off smaller bubbles which are there in the arterial system. Anti-epileptic medications like phenytoin need to be given. What are the precipitating events which cause arterial line air embolism? It mostly occurs due to non-usage of safety devices such as level alarms, arterial filters, bubble traps. It could be because of oxygenator related issues such as a break in the oxygenator connections, detachment of oxygenator from the holder, non-venting of oxygenator, clotted oxygenator. Pump related issues, most of which we have discussed before: runaway arterial pump head, reversal of the arterial pump, reversal of the vent pump, ruptured pump boot, over-occlusion, several things, pump-related causes. Cardiotomy reservoir-related causes, like positive pressure at the input of the reservoir, which causes air to be forced back up the arterial purge line. Then initiating veno-venous assist venous drainage. All these things can precipitate air embolism. Now, continuing this patient in the post-operative ICU, how are we going to continue management? This patient wakes up after 4 hours. He was moving all 4 limbs. You feel it is neurologically appropriate. But then after a period of 5 hours, again he gets a seizure where he's still intubated. Now, what next? If the patient had not been intubated or if the patient was extubated, I think it is safer to go back and intubate the patient because seizures can happen and repeat seizures can lead on to aspiration. So it's better to intubate. You need to get a CT scan head to assess the extent of damage. Hyperbaric oxygen is, if you have, is a good measure to use at this point of time. Other measures are intravascular volume expansion, use of lignocaine. Many of this your anesthetist would be able to help you with at this point of time. Some recommendations that in late air embolism or in later stages of air embolism, steroid and barbiturates don't help, but many recommendations still continue to have this. Intracranial pressure, if it is high, it has to be monitored and you have to take measures to reduce intracranial pressure. Shall I go into the next scenario? Is it okay?
I think continue. You're doing extremely well. I'm pretty certain people don't want to switch off at the moment.
Okay. Next scenario: elderly female, severe calcific aortic stenosis. There are some carotid Doppler shows some plaques. They don't need treatment. You've done a peripheral Doppler, right femoral artery showing 30% block. You've done a coronary angiogram, which was minimal disease, not requiring treatment. You planned for an aortic valve replacement. There are no obvious intraoperative events during initiation or performance of cardiopulmonary bypass. But however, when you come back to the ICU, the patient wakes but has difficulty in moving the right lower limb. Then you suspect neurological injury, you take a CT scan, you find that there are multiple ischemic areas which are suggestive of embolism. Now, what could have we done? What are the points of prevention in this case? What is the possible source of embolism in this case? It would have been the ascending aorta because the patient has several other sources of atherosclerotic, evidence of atherosclerotic disease, and ascending area is one area which we have not looked at in, or has not been mentioned in the case scenario. So probably that is what was missed in this case. Now, what are the preventive measures that are available to prevent in a situation of this kind? You should know that embolism happens in 1 to 10% of cases. So you should be vigilant, aware. And most of this is diagnosis dependent. In a younger child with a smooth aorta, unlikely to happen. In an older adult with atherosclerotic disease, more likely to happen. Now, during evaluation, if your chest X-ray has shown calcification, your X-ray has a 50% sensitivity and a 70 to 80% specificity. So it is good enough to make you suspect that something is there. And if you find aortic calcification, it is usually on the aortic knob or knuckle. Now, it is an indication that you go around actively looking for other signs of atherosclerotic disease. Like the recommendation is you ask for a CT scan of the chest. You are able to see both the thrombus and the atherosclerotic plaque. Both will be seen peripheral to the patent lumen as low density structures. You will also be able to locate in intramural calcifications. If a plaque is present and the thickness is greater than 4 mm, or you're seeing plaques with ulcerations greater than 2 mm, or presence of mobile thrombi, these are factors for high risk of stroke and also markers for coronary artery disease. So you have to take steps in evaluating for those conditions as well. Now, how useful is MRI? Not much when it comes to identifying calcifications, but in atherosclerosis, you are able to identify mural thrombus. And as always, MRI will help you to identify an aortic aneurysm that is there and that you have not seen. Intraoperative TE is a good measure to identify atherosclerotic plaques in the aorta. We'll come to that subsequently again. Now, on the pictures on the right are TE, epiaortic echo, and the clinical specimen of calcification. Now, at surgery, what are the measures or medications that you may get into trouble? Now, if you feel that your pericardium or adventitia is adherent to the ascending aorta, or unhealthy kind of tissue on the ascending aorta, indirect indicator. If your ascending aorta is looking unusually pale and you made a stab incision and there is very minimal bleeding, again indicator that you have entered an area where there is a plaque. Before you go into all this, you have to palpate the aorta carefully. How good is surgical palpation in identifying plaques? I'll come to that again with some data. But what is recommended is epiaortic scans. You use a 7 megahertz probe, ultrasound probe. You scan the entire area from the root to the base of innominate artery. A normal aorta should not have any identifiable intimal thickening. If there are areas of thickening less than 3 mm, without intimal regularities, you will think it is mild atherosclerosis. Moderate is more than 3 mm with diffuse irregularities or calcification or both. Severe is when there are more than 5 mm intimal thickening, or you have large protruding atheromatous debris or thrombi, extensive calcification or ulcerated plaques. Now, use of epiaortic ultrasonography is as class 2B indication to reduce incidence of stroke. Now, when you're doing aortic cannulation, whatever the scenario, it is preferable that you keep the systemic arterial pressures below 100 millimeters of mercury so that you don't disperse any thrombi or plaques or cause microembolism inadvertently. Now, in JAC, a comparison was made of the 3 techniques that we've discussed as used. Palpation of the findings, calcification. One was epiaortic ultrasound and one was TE. And they found that both TE and epiaortic ultrasound are better, significant statistically better than just palpation of the aorta. And between epiaortic ultrasound and TE, epiaortic ultrasound was found to be better than TE in identifying calcifications and atherosclerosis of the aorta. Now, if you find that there are issues, what are your alternate sites of cannulation that are available? Femoral artery, it is easy, but it is not preferred, especially in a case like this, because of concomitant disease and increasing chance of embolic episodes from below. You have chance of dissection, and inadequate flows and altered distal perfusion is always a problem which happens with femoral artery because it's a very distal cannulation. The other options are to go to the underside of the distal aortic arch. You can use a long arch cannula distal to the left subclavian artery. Axillary artery cannulation or a subclavian artery cannulation with side graft. What is done is an 8 mm Dacron graft is sewn, which facilitates arm blood supply in later closure. Use of axillary artery cannulation is a class 1 recommendation, especially in case of calcified aorta arch involvement or a porcelain aorta. It is recommended that you use the axillary artery or the subclavian artery for initiation and continuation of cardiopulmonary bypass. Is it problem-free? No. Chances of brachial plexus injury, axillary vein injury, and bleeding during throughout your case at the suture site because of heparinization, you can continue to bleed. There are reports that it causes significant blood loss at this site. What is your other option? The left ventricular apex. what can be done? You can make a 1 centimeter incision in the apex of the left ventricle. You use a 7 millimeter cannula. Previously, a Sans cannula was available. I doubt if it is still available, it is recalled, or I don't know if Medtronic has taken over this cannula. I'm not aware of that. But a 7 mm cannula, which is smooth, uniformly, of uniform dimension with stylet preferably, can be used to guide through the apex and across the aortic valve. Under TE guidance, you can position it in the ascending aorta. And that helps to avoid direct arterial cannulation. Okay, again going on to the preventive cannulation strategies. Your regular problems with the regular aortic cannula, the angled and the straight ones that we use, what happens when you use it in an atherosclerotic aorta is two terminologies that you have to mention. One is it causes sand blasting. It is going to, the jet of blood from the arterial cannula is going to just blast all the plaques that are available, that are present in that vicinity into the systemic circulation. So that is going to cause a gush of emboli into the brain and to the other circulation, the rest of the circulation. What are the options, newer options that are available in cannulas? One is a soft flow extended cannula. You can see that the opening in the aortic cannula here is on the sides. In both these cannulas, opening is on the side. You don't have an opening in the tip. So your jetting effect is not going to happen. You're going to get a smooth flow through the sides. There is a soft flow again, but a straight tip cannula. Again, openings here and openings here. Soft flow angle tipped cannulas. And cannula called a Select 3D2. Looks a bit scary, but supposedly used is very helpful if you have an atherosclerotic aorta. Then the Sans extended aortic cannula that I was mentioning. Then again the cardioplegia cannulas, again you have to be particular about what you're using. Either you go for a diffusion tipped cannula if you're using antegrade cardioplegia, or preferable that you go for retrograde cardioplegia. And what about aortic clamping? Aortic clamping is one step where you can have a MAC, again like the aortic cannulation. The clamping procedure and the declamping procedure can cause one, a gush of thrombi, and second, in an atherosclerotic aorta, the clamping, declamping itself can precipitate a dissection flap to form. So use of endoclamp is advisable in such situations. Now, okay. Now, what are the other recommendations against gaseous microemboli that can happen? It's not, this is in keeping with embolic episodes, not particularly an ascending aortic atherosclerosis. So you have to use a carbon dioxide flush in the both in to prime and to in the operative field, especially during redo surgery, so that gaseous microemboli do not happen. And what are the non-gaseous microemboli that can happen? Several things: microthrombi, platelet aggregates, red cell aggregates, non-particulate matter like particulate matter, non-human particulate matter like calcium, cotton, plastic fiber. All these things can cause embolism. So post-operative embolism could be something as major as emboli from an atherosclerotic plaque, or it could be gaseous microemboli or non-gaseous microemboli. So when you're looking at post-operative stroke, you have to keep all these possibilities in mind, and you have to take measures to avoid all these things. Now, a small scenario that can happen, which you should, I don't know if it is clear on your screens, but you can see a small water droplet trickling down here. And again, in this picture, you can see a water droplet trickling down, a faulty oxygenator. The best place and time in cardiopulmonary bypass is to identify it early and replace it before going on pump. So this would be one situation where you have done a preoperative checklist, you have identified, and you have averted a trouble, because we have seen how difficult changing the oxygenator on pump can be, and how much manpower is needed to change a pump, and when you're on pump, or change the oxygenator when you're on pump. So best place to identify preoperative checklist and identification of the issue. Now going on to next scenario. 34-year-old male, 58 kg, 170 centimeters. He's had a previous surgery for AV canal defect. Now he's presenting with severe MR, and you're planning to do a mitral repair or replacement. You find that RA is close to sternum. You confirmed it with the CT scan. You have initiated femoral bypass before sternotomy. When you have initiated femoral bypass, your perfusionist finds that the venous return is low, and he has added a vacuum to the drainage. Now your sternotomy goes uneventful. You release adhesions, and you decide to cannulate the ascending aorta. Now you have put aortic cannula, you have put an SVC cannula, and you have retained your femoral venous cannula. So CPB should be on aortic, SVC, and femoral venous cannulation at this point. At this point, your perfusionist is saying is not able to maintain flows because there is no venous return. And what has happened? And what has happened in this case is aortic dissection. What are the CPB related factors that you need to do? First, foremost, off bypass. You can fill the heart, clamp the venous line, fill the heart. I don't know how much is possible, because your perfusion is already saying that he's not having any venous return and your heart is empty. So you have to fill the heart probably by filling through the venous cannula. Disconnect, fill the heart. Then the next thing more possible you can do is you can connect the arterial line to one of the venous cannula that you're having. Easier to connect it to the SVC cannula and go on a veno-venous bypass and leave the heart ejecting, so that through the natural lumen, whatever blood is coming back to the RA or out to the RB, it is going to go to the systemic circulation. Again, not sure, because your perfusionist has already told you the volume is not sufficient. So you need to keep adding more volume to the reservoir and keep the flow maintained. Now, all these are stopgap mechanisms so that you can go on to definite aortic cannulation. Now, what is the next cannulation site? We discussed a lot of alternate cannulation sites that are available for use when we were in a couple of slides back. Which of those sites are we going to use now in this case? One is that you already have a femoral cannula in place. You can initiate, if you didn't have that, you could initiate a femoral cannulation, or in this case, you resume a femoral cannulation. But then how sure are you that your femoral cannula is not the reason for the dissection in the first place? Because your perfusionist had already told you that the venous return was less and he is going to add vacuum to the circuit. Had you already dissected at that point and had you not identified? So again, femoral cannulation may be not the best option available. The next option we saw was axillary cannulation. How easy is it to go for axillary cannulation? Again, I wouldn't think that it is going to be easy. Already you're panicked, you don't have axillary artery in easy access. So you would think of something which is more easily available for you to cannulate. Now, you could think of left atrial cannula. Then we had previously discussed the left LV apical cannulation, and reports of direct ascending aorta cannulation by what is known as a samurai cannulation technique. So these are some more options that are available, probably better options if you're in a real mess. Your ultimate aim is to somehow take the patient to a temperature and point where you can achieve TCA and you can repair the dissection under circulatory arrest. Now, at this point of time, you should remember that you have to give, you will end up having to give a retrograde or a direct osteal-collegial cannula for myocardial protection as well in this case. Now, what are the patient-related factors that you need to think of now? Again, in view of patient safety, ask for help. You should have, you may be able to make a visual examination and see areas of discoloration on aortic surface. Again, not sure, probably the whole aorta is dissected and you don't get any clue of what is safe, what is not safe. This is a good point where if you retain your cool head, you can ask for an epi-aortic scan to see the dissection flap and what has happened. Or your perfusionist or your anesthetist could go do a TE and tell you where the flap is. For more important than all these investigations for the anesthetist should to be focusing on would be cerebral protection, and somehow you have to hold the patient to go on TCA. Now we discussed direct ascending aortic cannulation or the samurai cannulation. What is that? Now that was reported by Kitamura in Annals of Thoracic Surgery. What they suggest is a technique which they have used in a lot of cases of type A dissections. What they've suggested is that you dissect and loop the ascending aorta. You get 2 umbilical tapes around the aorta and 2 snuggles on them. And then you also dissect and loop any of the branches that are visible to you and easily accessible to you. These tapes, the umbilical tapes are on the innominate vein, and the venous and the snares that you can see, the vascular loops that you can see are on the branches of the aorta. Now, after they have done this, they have put a venous line into the right atrium, and they have also introduced a vent through the right superior pulmonary vein. And then after draining the heart, they go on a transient or a very temporary brief period of circulatory arrest, where the surgeon pinches and holds the aorta with his left hand and directly cuts the aorta, transects the aorta. And then he is able to see the true lumen and the false lumen. And he guides in this aortic cannula through the true lumen. And immediately he snares the 2 tapes so that the cannula is retained in place. No blood is coming out, and you're able to initiate cardiopulmonary bypass for this. If you're able to do, it's good. If you're able to remember this technique, you're able to do, probably a good way to get you off trouble. Now, again, continuing with aortic dissections, it's known to happen, rare complications, and should be rare complications. 0.01 to 0.1% of cannulations. You have clues, you know early on in most of the situations that this is happening, but you just need to be aware that this is happening. Adventitious discoloration, sharp increase in arterial line pressure, reduction in venous return, all clues that you need to be, you need to go back and think, are we missing dissection at any given point of time with these clues? First and foremost, prompt aortic cannulation site to be changed. You need TCA for repair replacement. Survival rate, if you've done an early recognition, is fairly good, 85%. But you've made a late discovery, the chances of saving your patient is also less. So when you're doing femoral cannulation, what all things can you do to make it safe? We already discussed aortic cannulation. For femoral cannulation, what all things can you do to make it safe? And first is when you can use a Seldinger technique, and you can use that to place the guide wire in the distal thoracic aorta using TE, and then you place the femoral arterial cannula. Or better or more useful technique would be to do an open cannulation of the femoral artery between clamps. To cut the femoral artery, visualize the lumen, put in the femoral cannula. Or the third option is an external iliac artery cannulation. Again, you need to use an open technique to cannulate external iliac artery. In this particular case, the point where we could have identified trouble was when you heard that the venous return is not good. So maybe you had dissected at that point. So before initiating vacuum assisted drainage, you should have run your checklist, troubleshoot a checklist, and ruled out dissection at that point before continuing on bypass and peripheral bypass. Okay, next clinical scenario, I think it's a spotter. A lot of people would have already identified what is this. You have a lot of clots in your vein, in your reservoir. How does it happen? What have you missed? One is it could have this, in this particular case that I'm showing, it happened an hour into CPB in a redo surgery. Clots were noted in the reservoir. What are the possible problems? Could be reservoir related issues, manufacturing defects, something which is causing a lot of thrombosis, ACT related issues, or heparin resistance. Now, for ACT related issues and heparin, for obviously for reservoir related issues, you cannot do anything. You cannot find out early enough to do anything about it. For ACT related issues and heparin related issues, resistance and all that, there are a set of steps that you need to have in place. One is individualized heparin management. Rather than going for a blanket ACT of 480 or ACT of 300 to 600, it is recommended that individualized heparin management is done by titration. You can do that by using either the HepCon system, which uses patient's body weight, height, baseline ACT, and the heparin dose response to determine initial heparin doses. It is usually seen that with a dose of 85 units per kilogram, you're able to achieve somewhere around 300 to 400 ACT. So you can titrate your the next dose of heparin accordingly. How much more do you need to give? And using this method, it is found out that the heparin effect usually lasts for 1.5 hours. The half-life of heparin is 0.8 to 0.2 hours. And values return to 10% of baseline by 4 hours after the first dose. So your next dose of heparin has to be within 4 hours of the first dose. The same system can be used to calculate protamine doses as well. You can use to calculate how much heparin has been released from the body, cleared from the body, and then calculate your protamine dosage. Now, the next method is direct measurements of factor 10A, anti-10A levels. It's useful apart from cardiopulmonary bypass. You can use it for when you're using low molecular weight heparin as well. You can come back to these slides. They're very busy slides and some things which you really need to know. So you can come back to these slides at some point and look at them. And you can use blood heparin measurements in addition to the ACT. Now, it is also found in several reports that protamine dosing is significantly reduced when you use the HepCon system to calculate the heparin dose. Now, some words about protamine management. Protamine is used to neutralize heparin like we know in conventional CPB. It is based on the initial or the total dosage of heparin throughout the procedure. Now, tailored dosing models like heparin measurements, anti-10A measurements, they are better than giving a blanket dose of heparin, so 1 milligram of protamine for every 100 units of heparin used. That is a conventional thing that we use. So, better than that is using direct measurements of heparin and heparin activity. Dose-based calculation of protamine will help preserve platelet function, reduce coagulation disturbances. Now, there are guidelines, EACTS and the STS guidelines. Both are very similar in what they recommend for anticoagulation. Now, for heparin management, ACT recommended is 480 seconds, 2A recommendation. And what is the test you're going to do is, if you're having only ACT, you have to use ACT as a level to measure that. Now, if you are having heparin dose response formulas, you can use that. Heparin concentration monitoring in addition to ACT, very well and good. You can use both methods to do that. But in no way do you do cardiopulmonary bypass without checking ACT. That is class 1 recommendation. So, protamine, again, dosing can be calculated based on existing dose of heparin class 2 recommendation. Same for both guidelines. Now, protamine dose, like I said, you usually give 1 to 2 milligram protamine for 100 units of heparin. But it is better, the STA's recommendation is that you don't overdose it. You don't go more than 2.6 milligram of protamine for every 100 unit of heparin that is given. Now, what are the alternate anticoagulation methods available? Bivalirudin is not approved by FDA for conduct of cardiopulmonary bypass. And if there is renal dysfunction and heparin is a contraindication, argatroban is a drug that you can use, and again it has got a restricted use. And just try to give some points on this. Bivalirudin is a recombinant iridium analog. Therapeutic level is measured using Ikarin clotting time, whereas like you can also use the ACT. If you don't have ECT, you can use ACT. Baseline ACT value should be measured, and you target a 2.5 time baseline during conduct of cardiopulmonary bypass. Half-life is 25 to 36 minutes. It undergoes a proteolysis as major method of disintegration and clearance. Up to 20% undergo renal clearance. So one problem, and why if it is not FDA approved, is that blood stagnation, if it happens in the CPB circuit, it increases the risk of thrombosis. So you cannot use a conventional CPB machine for this. It has to be conducted by, when bivalirudin is used, the team has to consist of skilled perfusionists, skilled surgeon, and skilled anesthesiologist, so that you don't have too many issues and the surgery is not too prolonged. Lots of things. Not the ideal drug to use for cardiopulmonary bypass as of now. Now, what is argatroban? It's a L-arginine derivative. It undergoes hepatic clearance. Half-life is 40 to 50 minutes. It's preferred in patients with renal failure. No specific reversal agents are available for either of these direct thrombin inhibitors, either bivalirudin or argatroban. Renal replacement therapy or dialysis can reduce plasma concentrations of bivalirudin, but does not help with argatroban. So what is the dosage of 1 milligram per kilogram of bivalirudin, and then subsequently an infusion of 1.75 milligram per kilogram per hour. And argatroban is 2 microgram per kilogram per minute. And in renal disease, you give 0.5 microgram per kilogram per minute. Now, how safe is conducting perfusion? We saw a lot of complications, and we discussed how to manage them, and have these complications changed over time? So between the period of 1950 to 2000, around 165 cases and small series and case reports were found in literature, and most of them described air embolism or air incidents. Other issues leading on to perfusion safety were only 0.45%. If you look at the literature, predominantly in 1950s, they were discussing flow meters, safety devices for cardiopulmonary bypass, mechanical failure during cardiopulmonary bypass, and a lot of things like that. During 70s, more articles were on use of aortic vents, prevention of air embolism, dissection, runaway pump head, articles like that. Then during 1980s, we started having talks on safety devices, blood level indicators, oxygenator failures. So how safe is it to do cardiopulmonary bypass in current era? The risk is reported to be low, 1%. Common problems that we face now: pump failure, heater cooler failure, protamine reaction, oxygenator failure, electrical failure, massive air embolism, clots in the sequelae, inadequate oxygenation, arterial dissection, cannula dislodgement, gas supply failure, miscellaneous. Many of this we have tried to mention in the slides that we've discussed. So what is the recommendation? Current CPB circuit comes with several inherent safety checks so that you don't get into trouble. So it is imperative that you perform these safety checks and you have these safety checks in place. So going back to the circuit diagram, first thing that is available is blood levels when blood level alarms. Either it can lead to pump shut off or without pump shut off. This is how that looks. These are level detectors on your reservoir. And the next thing are high pressure alarms. You have them in 2 or 3 places in the circuit. One is in the arterial line and one is in the cardioplegia line. Okay. Then the next one is arterial line filter mentioned previously. It helps prevent massive air embolism. The single best thing that you can use to prevent massive air embolism, arterial line filters. Bubble traps are devices that can be used in the circuit for the same function as arterial line filters. They're slightly different as they're less costly, and the technology is also slightly different, but it helps to get rid of most of the bubbles, not the massive air embolism. Now, gas filters, previously mentioned at several points, gas filters. Then ACT monitoring device, the pre-bypass checklist, backup arterial pump head, backup heater cooler, backup oxygenators, emergency oxygen supply, hand cranks. All these are inherent safety checks and they have to be present in your cardiopulmonary bypass circuit. Now again, all these find place as class 1 recommendation in the current guidelines. You need to have monitoring devices in arterial line, cardioplegia delivery, bubble detectors, level sensors, backups for all components of heart-lung machine, and you have to maintain a maintenance plan of the cardiopulmonary bypass equipment. So you have a sense of when the next service is due for your equipment. Now, just a small quick steps as to what you do for some of the events that we discussed. You have an airlock. What do? Replace the air with fluid in the venous line. That transiently go off pump, go on pump again. Air embolism, first thing, one thing that you do, retrograde cerebral perfusion. You have dissected, what do? TCA, repair. IVZ tear, TCA, repair. Protomin reaction, you neutralize the effect of protomin. You support the heart till the protomin effects are gone. Pump failure, replace the pump. Now, we go to another, probably the last of the scenarios that I have now to discuss. You are part of an outreach team, which is operating in a remote part of this world. Okay. And none of your perfusion hardware have backup. You have a single heart-lung machine, single heat exchanger, boils machine, everything is part of CSR initiatives. You don't have any spare available in the center that you're going to operate in. Most of the disposable items you have taken with you, you have on limited stock, again CSR initiative. Now you're feeling all important that you're helping the needy who have no access to healthcare, and you're going to operate on this child who is going to benefit from your service in such a situation. While you're patting yourself on the back, suddenly there is a power cut. There is a person who can translate whatever you're saying, a local translator. The person gets back to you saying that the current will come only after 1 hour. You will find out that your pump doesn't have a backup battery, and someone has just gone to buy diesel for the generator. Your translator has thought of that and has sent someone to buy diesel for the generator. Now you're just starting your intracardiac repair. Now what is your lifesaver at this point? At this point, unless you're Dora or Doraemon and you can fish up a lot of things from your backpack or your tummy bag, the only thing that is going to help you in this situation is your hand crank, and use of hand crank and pump heads should be known. Okay, so this is one item probably you need to carry, whether or not you carry your toiletries with you, you need to carry this if you're going to an outreach center like this to operate. Different machines come with different type of hand cranks. For example, the angled one comes with thermo and the SANS machine. This is where the slot goes. In the SANS machine, you have to take off this white cap and introduce a hand crank there, and you rotate the crank. The straight ones go with the stockered machine. it doesn't go to the center here, it goes to the sides. It goes to these slots. And then you have to manually rotate the pump. You have to get a perfusionist or anesthetist or even the local translator or whoever is there to help you to run the pump at a speed which we have discussed, which will give some 100 to 200 ml of blood flow for the patient and wait for the electricity to return. Now I leave you with some words some of my teachers have told me always. Most problems in cardiopulmonary bypass are avoidable and they should be avoided. Don't get into trouble, and when in doubt, don't proceed. Don't hurry. You don't want to be the one who did a bad cannulation or ended up creating a trouble. For you, going on CPB has to be smooth. Coming off CPB also has to be smooth. There are no shortcuts in cardiac surgery. The step wherein you cut corners will come back to bite you. And anticipate and preemptive action is always needed. If you get into trouble, stay cool, call for help. You may always find somebody who is more calmer and cooler and who is able to navigate you out of the trouble. And always, like in driving, please don't forget the brakes. The brakes are the stopping the bypass and the heart-lung machine in this. You need to be aware of where the brake is and what brake to apply and what needs to be done. Some of the references I've used for the study. And lastly, and not the least, definitely is your team. And that team has to be aware of your strengths and you have to be aware of your team's strengths and weaknesses. And it is a fine-tuned, orchestrated process. You cannot get away without the help of any of your friends on the surgical team. Thank you for the talk.
Thank you, Dr. Saumya. This was just such a phenomenal talk. I mean, hats off to you. Well done, really well done. So first thing first, my suggestion to you is take a break, go get yourself some water, drink some water before we do any more discussion. Really so stop sharing the screen and go get yourself water. I'll hold fort before you come back. I've stopped recording, so just get yourself a glass of water. You need the break. I was going to suggest in between, but I said you're in a flow. So go get some water. I'll speak to the audience.
Was it too slow after a point?
No. It was absolutely fantastic. Actually, it was absolutely fantastic. For a guy like me who's a thoracic surgeon, I mean, I was enjoying this so much. So I can just imagine what the cardiac boys must be thinking. So really, really well done. So first, get yourself a drink of water. I'll talk to everybody, and then we'll discuss any points that they want to do. So my suggestion to everybody is that Dr. Saumya Ramanan has done a phenomenal talk. There are 12 scenarios in CPB which you need to be able to answer. These 12 scenarios are classic, and her last 3 or 4 slides very clearly stated the 12 scenarios and what you need to do in that. So my suggestion to everybody who's listening on this podcast is that please get yourself a 200-page notebook and please write down on the top the 12 scenarios on separate A4 pages and come back to this talk and write down what she wrote on the CPB side and on the patient side. I'll tell you, this exercise of writing down the 12 scenarios will help you for the rest of your life, because cardiac surgery is a career. Over your lifetime, you'll be doing 20, 30,000 cases. But if you have written down in your own handwriting all the scenarios and how to handle these scenarios, you will be in a much better position when it happens. And you have to keep going back and reading this text, because when the scenario hits, and you don't have time, your recollection should be instantaneous to be able to save the patient's life. So please take this lecture very, very seriously. And if I was you, I would go and watch this video at least 3 to 4 times. And I would write down each of the scenario, and below that, write down the list of steps to be taken. I mean, it's just been a phenomenal talk. One of the best I've heard. So well done, Saumya. And now, if anybody wants to ask any specific questions, we'll take it. There were 1 or 2 questions which people have asked, but I think it's been a very detailed lecture. So let's not get into the semantics of things. We can revisit these scenarios at a future date. But anybody's got anything specific that they want to say? Mohammed Lamar is asking about how do you learn these things for a young surgeon. I think, these scenarios, if you write them down and you discuss with your seniors, and I hope you never see them, then you're okay. But most of the people have come across these scenarios, at least one or two in their careers. Saumya, how does one learn how to act in these scenarios?
So first and foremost, I think you have to stay cool. I have seen a lot of my students, my seniors, and staying cool when you're in trouble is something which has to be learned as you train. You cannot be an impulsive person. You get everybody on your team also anxious. Also, you get shouted at by somebody. Your thinking just stops. You cannot proceed after that. Then you just stand there and you freeze. You cannot help the surgeon. You cannot help the patient. The first thing, what has happened has happened. Stay calm, stay cool, and then just see how you can go forward. That is what I tell my residents. That is what has helped me.
One thing I noticed from all your slides is the first important line that you wrote everywhere: ask for help. The reason you ask for help is not because you don't know what to do. The reason you ask for help is because your adrenaline is running high and somebody else walks in. He will have a cooler state of mind. He may just guide you to what is the next step. So ask for help is get somebody else in the theater. Get perfusionists, get another surgeon in the theater. It is never an ego issue when things go wrong. It's always you need a live patient out of the theater. And when somebody else walks in, he's in a much cooler state of mind to make decisions than you. So I think ask for help is the most important thing. I worked with Bob Bonser in Birmingham, and I noticed that the moment things went wrong, he became cooler. His voice became, more crisp, more precise, and he took control of everybody's action. So he would tell the anesthetist what to do. He would tell the perfusionist what to do. He would tell the assistant what to do. I've said this before to you as well, but he was like Bjorn Borg in tennis, cool. And he used to become even more cooler when things went wrong. So don't throw tantrums, don't shout, don't raise your volume. Ask for help and calm down. Take a deep breath, calm down. You might save the patient's life. Okay, there was something else which Biswarup wanted to ask. There was a recent problem in an adult patient with regurgitating lesion, tall guy, flow was calculated at 5.2 liters. In India, the largest reservoir is 4.5 liters. So what do you do with that?
I think you just 4.5 and 5 should be okay. Somebody in adult who can help, Vikas probably can chip in and say what they do. 4.5
Vikas,
flows for a 5.
I did not understand what is his doubt actually.
Because no, that's fine. Let's leave it. It's a very complex talk, and let's not confuse everybody a bit more because people are tired. It's been almost 2 hours and 20 minutes. So we can discuss this on the thoracic gurus. Biswarup, put up your question on the thoracic gurus, and we'll discuss it on there. I can see that Kamran is still with us. Is Kamran Beg still with us? Kamran, are you still with us? Hi, Kamran. I want you to come in and comment on this talk. It's a very, very important talk. And give us some highlights on what to do and what not to do.
Well, this is, I was following this talk in different phases. I was traveling in the car, then I was at home, and now my son is sleeping next to me, so I couldn't engage. This is encyclopedic. I think it started off very well because many of us, you can read a textbook. We are taught, the people who are taught about perfusion, there's a book called The Gravely. They call that the Bible of perfusion. This talk exceeded even that because that is a very dry book, a lot of figures and text. This took it all and updated it, and I think the reference that they gave was the European Society guidelines. Many of us probably have that, but actually this made it very interactive. So I think it's a great reference, and each of us will have to go to it a few times and take even many aspects, because the details on the cannulae, this relates to, for instance, when you have your exam, they can give you an aortic cannula, venous cannula. If you answer it with this level of detail, you talk about the flow, you talk about the different aspects, that will give you, will really highlight your answer. And then the scenarios, of course, these are practical scenarios, and they were nicely mixed in between the different aspects of the talk. And I particularly enjoyed all of that. And the way it was all nicely clinically correlated. So very well done. Perfusion is something that we don't address much, and these days, what we have now, and we have some very good simulation. So there are simulation models to go through some of these. They have a very nice model. One of our perfusionists, Salman Butt, is online. He can maybe comment, called Orpheus, which is what they use for training the perfusion trainees. So there are some simulation models coming out, and I think that's very good.
Fantastic.
So when it comes to studying this topic, I think this should be the reference. You have to supplement it, because some of the basic science, which they will also ask in the part 1, comes into this: the inflammatory response to bypass, the coagulation effects, the effects on different systems such as complement. These are minutiae that they will test in the part 1. In the part 2 exam, there will be definitely scenarios. There will be parts of the bypass machine. There will be conduct during different emergencies. So very well done.
Thank you, Kamran. That was very helpful. So I think since it's been a long session, I don't want to prolong this anymore. The reference which is given is a very large document. It's, as she said, it's almost a 40-45 page document. So we need to make sure that you convert that document into a. Sorry, just one second. My voice is.
You need to make sure that you convert that
document into points, and the way to convert it into points is what Saumya has done. So please write this out by yourself. That's the only way to learn it. And then the better way is 2 of you get together, one asks the other the question about the scenario, and you feedback, because reproduction in the exam is all about practice. And if you haven't practiced it, because it's not possible that you would have seen all these 12 scenarios in your 5 or 6 years of training. So it is very important that you learn to speak, So please put it point wise, 1, 2, 3, 4, 5, 6, and then please reproduce. So practice with each other, or practice with your wife. Tell your wife to hold the book and ask you the question. And I promise you, this lecture is going to change your life forever, for a long time. So thank you, Saumya. I am really, really grateful. Any other discussions or any other questions? My suggestion is you put it on the Thoracic Gurus group, and I'll be very happy to forward it to Saumya, and we'll get them to be answered. Okay, and I will make sure this goes on the Thoracic Gurus YouTube channel as soon as. So tonight I'll try and put it up there. Thank you very much, everybody. It's been a phenomenal experience.
Thank you so much, sir. Thank you so much, sir. Thank you.
I seem to have lost your voice.
Hello?
Thanks. Sorry, I lost your voice because my iPod ran out of batteries because your lecture was so beautiful. Thank you. Is any other pressing issues? Anybody's got any pressing issues you want to talk about?
Nothing from my side, so I think we can call it a day.
Okay, guys. Thank you very much and good night.